I'd like to introduce our speaker for today, Dr. Kristina Bryant. Dr. Bryant is the Associate Medical Director at Louisville Metro Department of Public Health and Wellness, Hospital Epidemiologist at Norton Children's Hospital, and NCMG Medical Director for System Pediatric Epidemiology and Infectious Diseases. Dr. Bryant is a professor in pediatrics at the University of Louisville School of Medicine, and she is a past president of the Pediatric Infectious Diseases Society Board of Directors and a co-editor of the Pediatric Infectious Diseases Society sponsored Handbook of Pediatric Infection Prevention and Control. Dr. Bryant was appointed to the American Academy of Pediatrics Committee on Infectious Diseases in 2021 and is the physician lead for the Red Book Online. So welcome, Dr. Bryant. She will be talking to us and giving us a pediatric infectious disease update.
Thanks so much, Dr. McDonald, and hello to everyone. Let me share my slides. And let's get started. I thought we would do this in terms of 10 questions and 10-ish answers. My disclosures are listed on this slide. I've been a principal investigator on studies funded by Enanta and Sanofi, and I've received royalties from Oxford University Press. As Dr. McDonald said, I'm a member of the AAP Committee on Infectious Diseases, but I'm not speaking on behalf of AAP today. All right, so let's jump right in. And question number one. This is a call that I received yesterday and last week. These calls are increasing in frequency. Do I need to test this kid for measles? So I've seen something that I like to call the measles action potential phenomenon. So as measles cases increase locally, let's say not in Louisville, but in the state or in surrounding states, as media coverage goes up, we all become more aware. We hone our practices for promptly isolating kids with fever and a rash. The calls about testing go up, even about kids maybe who are unlikely to have measles. And then things start to die down. We come back to our baseline. I want you to notice under the dotted line, under the resting membrane potential, we don't want to be there. We don't want to be underprepared and under testing kids. So we need to find a happy medium. How do we appropriately identify kids who might have measles and need testing? All right, well, we're certainly on the uptick of the action potential because there has been measles activity in the state. Some of you may have seen this notice from the Kentucky Department for Public Health in early January. Cases of measles were diagnosed in Jessamine County. These kids, I understand, were exposed by an out-of-state visitor. And to date, we've had 4 cases of measles in the state, all in Jessamine County. We have had no cases in Metro Louisville this calendar year. You know that we did have 2 cases in Metro Louisville last year, as well as the case in a child who was traveling through. On a national level, there are lots of measles cases. Note that since January of 2025, there have been more than 2,700 cases of measles in the US. It's probably not hyperbole to say that number is increasing, if not every day, every week. The outbreak in South Carolina has now surpassed 789 cases. That's now bigger than the outbreak in Texas that consumed much of our attention from last year. This is a measles tracker map that is published by Johns Hopkins. And so if you are looking for additional information about measles, this is a good source. Another good resource is this map put together by Boston Children's Hospital, Harvard Medical School, and the Icahn School of Medicine at Mount Sinai in collaboration with ABC News. So you can click on your county and understand a bit about the risk for measles. For interest, I've clicked on Jefferson County, Kentucky. We are at a higher risk level, not the highest risk, but a higher risk level, um, in part because our state had 13 cases of measles last year, and in part because our MMR vaccination rate for kids under 5 is lower than we want it to be. All right, so let's come back to our case. There's measles in the state, measles around the country. Let's talk about a couple of cases. So this is call number 1. Chris, what do you think I should do with this kid? 5-year-old with fever, cough, and congestion. There's a morbilliform rash on the trunk. Well, what's morbilliform? Well, it's a red coalescing maculopapular rash. That's the term we classically use to describe a measles rash, but in truth, it can be seen with other things. The eyes were injected, and this child had a history of 2 age-appropriate MMR vaccines. There was no known exposures, no travel outside the metro area, and the child had a group A strep PCR that was positive. Now, the pediatrician noted that the rash was not scarlatiniform, and so the pediatrician was not convinced that this child had strep and did not have measles. So, what do you do? Um, I'm going to share an algorithm that we use at Norton Children's Hospital. It is based on a beautiful algorithm put together by our colleagues at Kentucky Department for Public Health, as well as CDC. So let's just work through this. This is an algorithm that can be used when there's no local measles transmission, and that's where we are in Jefferson County. The cases in Jessamine don't mean that we are having local measles transmission. All right, so a patient needs, let's start upper left-hand corner, fever, yes, for this patient. Maculopapular rash, yes, kind of generalized, and no vesicles. So when there are vesicles, that's not measles. Might be chickenpox. We're seeing a fair amount of that these days, but that's not measles. So I think we can say this patient meets those criteria. What about epidemiologic risk factors? No international travel, no domestic travel to a place where measles is spreading, and no known exposure to measles. So we'll move to the right since all the answers were no. Um, there are some clinical criteria: fever, rash, cough, runny nose, and some conjunctivitis. The patient had received 2 MMRs, but not within the last 21 days. And that's important because sometimes kids after measles immunization can develop fever and rash. And when you test them, they'll test positive for measles. So this patient had not received a very recent MMR, but they were appropriately immunized for age. Which is reassuring. The guidance from public health colleagues is that measles is uncommon among people with age-appropriate vaccination. It happens occasionally, but rarely. Um, and if measles is suspected clinically, call public health. Now, realistically, whenever we suspect measles, we should promptly isolate a patient in a negative pressure room if one is available. If that is not available, we put the patient in a room with a door, close the door. If we have a HEPA filter, we can put a HEPA filter in the room, and of course, we mask patients over 2 and their family members. This patient was isolated, and we reached out to the state, and they said, don't think this is measles. Reassuring that he's had 2 vaccines. The pediatrician was still concerned. In that case, we did not send the test to the Kentucky Department for Public Health for testing. We did send it to a reference lab, and thank goodness the test was negative. But kudos to the clinicians involved for thinking about measles. All right, let me share another case with you. 16-month-old with cough and congestion, fever about a week ago. The kiddo was diagnosed with an otitis media and placed on amoxicillin. The parents weren't really sure if the kid still had fever. On exam, there was no conjunctivitis or mouth lesions. The kid was still sick approximately 24 hours before presentation to an acute care setting. A rash developed that was concentrated on the trunk, didn't seem to start on the face and spread down. Um, the family initially said, oh, yeah, immunizations are up to date. And kudos to the emergency medicine physician who looked in the chart and didn't find immunizations documented, called the primary care doctor, found out, in fact, this patient had not received any MMR vaccines. There was no known exposure or travel, though. So, fever-ish, yes. Maculopapular rash, no vesicles, yes. Um, the child did not have epidemiologic risk factors for measles, no travel, known exposure, but did have clinical criteria. And if we just work down vertically, no recent MMR vaccine, no MMR vaccines at all. Um, and so in this case, we called the state health department, and they agreed with the concern for measles. A test was sent to the Kentucky Department for Public Health Lab and is now we are awaiting that result. So again, kudos to colleagues for thinking about measles. And I encourage everyone to stay alert and have a plan for your office. If you are in an office that does not have a plan for what you would do if a child came in with a story suspicious for measles, give me a call and I'll help you work through that. All right, question number 2. As MMR rates have fallen, measles cases have risen. I've shown you data to support that. So what's happening with the other M? What's happening with mumps? Well, in 2025, there were more than 300 cases of measles in the US. These were spread out among 38 jurisdictions, including 11 in Kentucky and 8 in Indiana. I will tell you that 2 of these cases were actually in Jefferson County. Now, our mumps immunization program has been a success. With routine immunization against mumps, cases fell. But since 2006, we've had more cases, several outbreaks. Cases do occur in individuals who have received 2 mumps vaccines. Um, the 2 cases in Louisville were not completely immunized for age. And I want to talk for a minute more about that. So on the left, you see a picture of a child from Redbook Online, our visual images library. You can see a child who has swelling over the parotid and some erythema over the angle of the jaw. The state has put together a really nice algorithm for when to suspect mumps and how to test. I'm not going to walk you through this step by step, but if you suspect mumps, please order a PCR test for mumps. This is done on a buccal swab, and that is the most appropriate test. Not a mumps IgM. IgM tests are problematic. There can be false positives. A child who has parotitis and just a positive IgM is considered a probable, not confirmed case of mumps, and it would be great to confirm these cases if we can. So if anybody needs a copy of this algorithm, please let us know and we can share this after the call. All right, question number 3. The AAP published their 2026 immunization schedule on January 27th. What do we all need to know? All right, so this is a copy of the immunization schedule. And I want to highlight that this schedule, the AAP schedule, has been endorsed by a dozen medical and multidisciplinary professional societies. I won't call out each one, but please note that ACOG, AMA, the American Pharmacist Association, the National Association of Pediatric Nurse Practitioners have all endorsed the AAP schedule. And so there is broad multidisciplinary support. Let's talk about some key updates. There actually aren't a whole lot of substantial updates. There are some new references, and let me walk you through some of the highlights. So, for RSV, clesrovimab was added as an available product for RSV immunization of infants less than 8 months of age. I think most of you are familiar with nirsevimab. That was a monoclonal antibody that became available a couple of years ago. Now we have two options. The main difference between clesrovimab and nirsevimab is that clesrovimab can only be used in infants under 8 months of age. So it's a first season drug, not a second season drug. There also was information added on how to report clinically significant adverse events that occur with RSV monoclonal antibody products to MedWatch. We don't report to VAERS because this is not a vaccine. It's a monoclonal antibody. It's an immunization. You would report to VAERS if the monoclonal antibody product is administered on the same day as a vaccine and you can't tell the difference. There are also some COVID-19 updates. So really the schedule was just updated to align with the AAP policy statement that was published last year. Recall that AAP recommends COVID-19 immunization for all children 6 to 23 months of age because they are at higher risk for COVID complications. Vaccination is also recommended for children older than 23 months who are at higher risk for complications. They have a high-risk medical condition or they live with someone at high risk. It's also recommended for kids whose parents want to protect them against COVID-19. You know, there were some changes to FDA approvals for COVID-19 vaccine. The package inserts changed. Those are noted in the AAP schedule, and the AAP COVID-19 vaccine dosing guide was added for reference. What about MMRV? There is an updated note to align the schedule with AAP policy, noting that AAP expresses no preference between MMR plus monovalent varicella vaccine or MMR combination vaccine for toddlers receiving their first immunization of this kind. Now, why do you want to know about this? So CDC updated recommendations for immunization and have said don't use MMRV under 4 years of age because of the increased risk of febrile seizures. The AAP believes you should talk to parents about this risk, but you should be, if you want to use it, you can use it. This is probably a moot point because MMRV is not covered in the Vaccines for Children program for children under 4. But I just highlight this as an update in the AAP schedule. We have a new combination meningococcal vaccine called Penmenvy. This is a pentavalent vaccine that protects against MenACWY and MenB. Just like Penbrea, this is an alternative to separate MenACY and MenB vaccines when both vaccines are indicated on the same day. And then finally, dengue. Dengue vaccine is no longer being distributed in the US. It was discontinued in September of last year. There may still be vaccines around, and they should have a beyond use date of September of this year. And then finally, HPV. The HPV age range in the immunization schedule was changed to 9 to 12 years to initiate this series to be in line with AAP existing policy. So this is from the Red Book. The Red Book is AAP policy about infectious diseases, and AAP says start the HPV series between the ages of 9 and 12 years at an age the pediatric healthcare professional deems optimal for acceptance and completion of the vaccine series. So there's a lot of leeway for when to start the series. You can start it as young as age 9 if you think that is appropriate. Why would you do that? Well, there is accumulating evidence that initiation of the HPV series at 9 to 12 years of age is not only immunogenic, but it's associated with higher rates of series completion. It also just may be easier for a couple of reasons. For families that are worried about multiple shots at one visit, this it makes that 11 to 12-year-old health maintenance visit a little bit easier. It's one less shot there. And it also decouples HPV from the discussions about other sexual health topics that are brought up at the adolescent immunization visit. We know that this is a vaccine to prevent cancer, and that's why we give it. I'll also highlight that this is Cervical Cancer Awareness Month for a few more days. And so I wanted to mention that in light of the importance of HPV vaccine. All right, so I suspect this is well known to everyone on the call. The AAP recommended vaccination schedule looks quite different now than the CDC HHS vaccine schedule. Earlier this month, Health and Human Services announced changes to the CDC recommended immunization schedule for children. Instead of the 18 diseases that are routinely recommended for vaccination in the AAP schedule, CDC now recommends protection routinely against 11 diseases. Those are listed in the blue box on the left-hand side of the slide. CDC now has 3 ways they categorize vaccines: recommended for all, recommended for high-risk groups or certain populations. High-risk groups in certain populations now includes RSV, Hep A, Hep B, and meningococcal. From what I can tell, the RSV recommendation hasn't changed really because it's always been recommended for certain populations, right? Kids under 8 months of age whose mothers did not receive vaccine during pregnancy, but that's how it's categorized. And then other vaccines are recommended based on shared decision making. The CDC had previously moved COVID-19 vaccine for children into this category, but now shared decision making includes rotavirus, influenza, Hep A, Hep B, and meningococcal. So, what changed? Why did this happen? Well, let me tell you what didn't change. There's been no new evidence, no new scientific interpretation of the evidence, no change in the risk and benefits of vaccines. The Kentucky Department for Public Health urges clinicians to follow the AAP recommended immunization schedule. All of the vaccines on the schedule, no matter how they're classified by CDC, continue to be covered by insurance and the Vaccines for Children program. Remember the caveat with MMRV. And immunizations required to attend school in Kentucky have not changed. The immunization requirements in Kentucky are not linked to a specific immunization schedule. They're actually called out individually in Kentucky administrative regulation. All right. Let's talk for a minute about flu vaccine. I think a lot of pediatricians were really confused and some upset about what appeared to be a downgrading of the national recommendation for flu vaccine. This came on the heels of a severe flu season for kids last year. Last year's flu season was a high severity season for people of all ages, but we had a record number of pediatric deaths from flu, 289. This is the highest since CDC began counting. And CDC has reported that 90% of kids for whom they have data were unimmunized against flu or incompletely immunized against flu. All right. So, in the discussion that has ensued, some people have said, well, is flu really that bad for kids? Is this year's flu season really that bad for kids? Um, if you want to leave a note in the Q&A about what you're seeing with flu, that would be welcome. Let me show you what I know. So 2025, 2026, this season is a high severity flu season for children. It's a moderate severity season for people of older ages. That's an in-season assessment and can be updated as the season goes along. Note the figure on the right. This is weekly influenza associated hospitalization data collected from fluserve.net. And this is available on cdc.gov on FluView. Note the high hospitalization rates in kids under 18 years of age. What I'm showing you in the figure is all data about children over multiple flu seasons. This year's flu season is in red, and note that peak. This is the highest peak of weekly hospitalization rates observed since the 2010-2011 season. Interestingly, you've probably been hearing that flu activity in some parts of the country are have fallen for a couple of weeks, or seem to be stabilizing. But CDC reports that emergency department visits in school age kids are over the last week prior to the snow across much of the US were ticking back up. They were increasing, so we'll see what happens there. There have been 44 pediatric deaths to date. 90% were not fully immunized. Some of this is just immunization rates. These kids are unimmunized. Only 42% of kids were protected by vaccination at the end of December. I think we're now at 44%, but immunization rates for flu in kids have fallen every year for the last 4 or 5 years. We continue to see antiviral treatment be underutilized. I just want to remind you of the AAP recommendations for antiviral treatment for children. So antiviral treatment is recommended for all children hospitalized with flu, no matter how long you've been sick. Any child with severe illness, no matter how long you've been sick. Any child with complicated illness, again, regardless of how long you've been sick. And children at higher risk for complications. And this includes young children. Uh, we know that kids under 5 have higher rates of hospitalization. The rates are the highest in kids under 2. And so if you are seeing kids with flu, especially kids under 2, but AAP would extend that to kids under 5, please talk to the family about antiviral treatment. All right. Does flu vaccine work? And we might amend that to say, does flu vaccine work this year? And I will say that the preponderance of evidence year over year is that flu vaccine protects children against the most severe outcomes of flu, including emergency departments, hospitalization, and death. Doesn't prevent every case of flu, but it does protect against severe outcomes. And we know that a vaccine effectiveness varies from year to year, but um, it consistently works. I'll share this recent paper from Pediatrics published in January of this year. This again was a CDC initiative to look at 5 influenza seasons, and it was an investigation to look at how effective was flu vaccine in preventing emergency department visits and um, uh, hospitalizations from flu in kids with and without underlying conditions. And so over 5 seasons, vaccine effectiveness against ED visits or inpatient hospitalization was 53%. In kids with underlying conditions, it was 43%, but note that there were overlapping confidence intervals there. So pretty similar. Um, um, Now, there was also pretty significant variability between underlying conditions. So, vaccine effectiveness was highest in kids with endocrine disorders and lowest in kids who had underlying respiratory conditions. The authors of this paper pointed out that, the need for hospitalization and the development of complications to some extent is dependent on the underlying condition. So immunocompromised kids, they may get flu vaccine but not respond. Kids with underlying medical conditions may not get so sick from flu, but maybe they're hospitalized because flu exacerbated their underlying asthma or chronic lung disease. But take home point, flu vaccine does prevent hospitalizations and ED visits in kids with and without underlying medical conditions. How effective depends on the year and the underlying condition. All right, well, what about subclade K? That's 5 seasons, but not this season. At the end of last year's flu season in the Southern Hemisphere, there were mutations of the influenza A H3N2 virus that was circulating. This influenza A variant is now called subclade K, and that is really the strain of flu that's been circulating in the US and in Europe and in Japan. So this strain, this mutated strain of influenza A H3N2, drove early flu seasons in Europe, and particularly severe seasons in some countries, like the United Kingdom. There have been some early season assessments of vaccine effectiveness, which for this European CDC study was a positive test for influenza at a primary care site. This is not looking at hospitalizations or ED visits, but simply a positive test at a primary care site. Vaccine effectiveness, where subclade K was circulating, was 52% in kids 0 to 17 years. So I will say there is still some benefit to this year's vaccine, and it is not too late to vaccinate if you encounter a child who's not yet been immunized. All right, so let's shift gears. Let's move from influenza to another favorite respiratory virus. What is the real world impact of RSV prevention efforts? All right. We already talked a little bit about RSV prevention. We have 2 different strategies. We can immunize pregnant women with an RSV vaccine. There is one RSV vaccine that is approved for this indication. Immunization is recommended between 32 and 36 weeks gestation. And then we have two monoclonal antibody products. The first to be available was nirsevimab. And that's really what this slide is about. This is data from a paper published late last year in the CDC's Morbidity and Mortality Weekly Report. Kids who, and it looked at severe outcomes, kids who were admitted to the intensive care unit from RSV and or had respiratory failure. They looked at these children and determined had they had nirsevimab or had they not. And what did they find? Well, they found that nirsevimab was about 80% effective against ICU admission, and 83% adjusted effectiveness against acute respiratory failure. Now, effectiveness did decline with time since immunization. It was highest, 86% in the first 60 days after immunization, but was still effective after that, just at lower numbers. All right. I'm showing you some data from Norton Healthcare. This is patients testing positive for RSV weekly. Full disclosure, this is not evidence for effectiveness of nirsevimab. We have not looked at every child who tested positive for RSV to determine if they've had nirsevimab or not. But look at the green line. That's patients at the hospital testing positive for RSV in our system this season. And then if you look at the red line, the blue line, and the yellow line, those are patients in the hospital testing positive for RSV in the three most recent seasons. The peak of RSV cases is certainly lower this year. And I think this is certainly deserving of further study. All right, so nirsevimab works. Maternal immunization works. How many kids are being protected? And I will say that, again, this is data from CDC. The short answer is not enough. This is data from last season, and it looked at how many infants were being protected against RSV. And 29% of infants born October to March were immunized against RSV through receipt of nirsevimab or through maternal vaccination. There was significant variability by state, ranging from around 11% to 53%. On the right, find your state. Kentucky was just under 30%. I will say that more infants in Kentucky received nirsevimab than maternal immunization. In Indiana, Indiana was just a tiny bit lower than Kentucky. And it looks like maternal immunization was more frequent than in Kentucky, but more infants still received nirsevimab. We have an effective tool. We have effective tools, I will say. We have maternal immunization and nirsevimab and now clesrovimab, but we are not using them to the extent that we could. All right, this is a call that I received last week asking for a friend. Which is more effective, immunizing mothers against RSV during pregnancy or immunizing infants after birth? My stock answer is, well, we don't know really, because they've not been studied head to head. There have been no prospective randomized trials comparing the options, and professional societies and public health authorities do not express a preference. Let me emphasize that. Nobody expresses a preference. There are one strategy may be better for a particular family than another. And so Is it still true that we don't have data? That's the part that's changed. We have a little bit of intriguing data, and it's data from France. This was published in JAMA very late last year. There was a prospective observational study done in France that compared infant immunization with nirsevimab to maternal RSV immunization. There were some really neat things about this study. First of all, it used a French national health database that collected lots of information about mothers and babies. I don't think we have the same level of data here. In France, in birthing hospitals, babies are offered our nirsevimab before they leave. That's also different than here, as you know. They had data in the database about more than 100,000 infants who were born between September 1st and December 31st. Of the season, and 85,000 infants qualified for the study. What they did was they looked at infants who were admitted, hospitalized with RSV, and they matched infants who had received maternal immunization with infants who had received nirsevimab. They were matched on their nursery discharge day, and they matched on a lot of other factors as well, gestational age and others. What they found was that nirsevimab was more effective in preventing hospitalization for lower respiratory tract infection. Both were effective, but the hazard ratio for nirsevimab was 0.74. For most other outcomes, secondary outcomes, including intensive care unit admission, need for ventilatory support, also favored nirsevimab. I don't tell you this to change your practice. Professional societies and public health experts in the US do not express a preference, but this is intriguing data that really deserves further investigation. All right. What else can I tell you about RSV immunization? That we are coming to the end of the time frame of the season in which we immunize pregnant women. Maternal RSV vaccination, remember, concludes at the end of January. This is a reminder from the state. And immunization should occur no later than January 31st. This is an important message, I think, because some maternity hospitals in the state last year continued to give maternal RSV vaccine to kids sort of throughout the RSV season. And if a child is born to a mother this season after vaccination, they can't get nirsevimab next season unless they have a high-risk condition. And so we had infants born to mothers who were immunized in late spring. The infants probably didn't get a lot of benefit from that immunization because RSV season was drawing to a close when the babies were born. And so don't do that. Newborns should continue to be immunized through the end of March. If for some reason RSV goes away and stops circulating and it doesn't make sense to continue giving nirsevimab, we'll let you know that. But right now, the plan is March 31st. All right, question 9. What do I tell parents about the birth dose of hepatitis B? This has been a hot topic because of recommendations on the CDC schedule. The AAP does still continue to recommend the birth dose, but I suspect some of you are having this conversation with moms in your practice or that you take care of in the nursery. Okay, I get it. It makes sense from a public health standpoint, but why does my baby need hepatitis B in the nursery when my test was negative? My colleagues at the AAP in the section of gastroenterology tell me that this is a very common question that they receive from friends and colleagues in primary care. And we are actually working on a short webinar to help address some of these questions. So let me share this. Um, our hepatitis B immunization program has been a tremendous success. Lots of parents have never seen hepatitis B. They haven't thought about it. It's not on their worry list. I'm guessing many of you in the audience have fortunately never had to take care of an infant infected with hepatitis B at birth. But this is a terrible disease. 90% of infants infected with hepatitis B at birth develop chronic infection, and 25% are going to go on to develop life-changing complications like cirrhosis and liver cancer. But we can prevent that. So, note what's happened since universal hepatitis B vaccination was recommended in 1991. There's been a 90% decrease in cases of young infants infected with hepatitis B. Universal vaccination is a very effective public health strategy. Okay, but back to our mom. What about me? My test is negative. I will say that universal Hep B vaccination also benefits individual mothers and babies. Now, again, this is a little bit tricky. Some moms miss testing. We do not test all moms for hepatitis B. The current estimates are that 12 to 18% of delivering moms across the US don't get tested. And so universal Hep B protects them. Even moms who do get tested, you all know that no lab test is 100%. There are false negative tests. This is rare, but it happens. Tests can be misinterpreted. Tests can be unavailable at the time of birth. Not all information systems talk to each other, and sometimes we are not operating with all of the information. Even for moms who say, I'm negative, we can share that transmission is possible from household members other than mom. We don't test everybody in the household. And historically, if we look at cases of Hep B in children, about half were perinatal and half were from household transmission. Hepatitis B vaccine is very safe, and this has been extensively studied over many years and many doses. So continue to recommend Hep B vaccination at birth, and more help is on the way to answer that question. My very last question for you today is, what do I tell parents if they ask about the immunization schedule in Denmark? I wish I could see you in the audience to ask you to raise your hand. Have you gotten this question? Have you received it from a patient or a patient's family? Maybe you received it from a friend or family member of your own. All right, so what I will tell you is that Denmark's immunization schedule works for Denmark. Denmark is a small country. It's about the size of Maryland. Denmark has free and universal health care. Each parent in Denmark has 24 weeks of parental leave if they're living together when the baby's born. And one parent is able to transfer part of that leave to the other parent. Is anybody quickly doing the math? Each parent gets 24 weeks of leave. That means that kids don't necessarily need to go to daycare until the end of the first year of life. There is also a program in Denmark called the Child's First Sick Day program, where parents can take off on their child's first day of illness. We don't have that here. And Denmark actually has better baseline health metrics than we do. They have a healthier population, they have fewer preterm births. And so each country crafts their immunization schedule based on the diseases that are circulating, the needs of their population, and their own healthcare infrastructure. Denmark's immunization schedule works for Denmark, and the AAP immunization schedule has been shown over many years to work to keep children in the US healthy. All right, so I'll close with a few resources. The AAP has a webinar coming up with the Common Health Coalition. It's called The Latest on Childhood Immunization, Practical Guidance for Clinicians. It's going to take place on January the 28th, and pre-registration is required. If you would like to get the link, if you go to Redbook Online and look at the news column, there will be a registration link there. I've also included a link to the North Dakota State University Center for Immunization Research. They have a beautiful webinar called What Changed? What Matters? Navigating Vaccine Schedule Updates. If you want to learn what shared decision making really is and isn't, check this out. I'll stop there. Thanks
All
very
right.
much.
Thank you, Dr. Bryant. All right, let's get to some questions. So this was concerning influenza. So where were the deaths across the United States? Is there a map kind of detailing where those deaths were?
Yeah, it's a great question. I have not seen a map. I know we've had at least one death in Kentucky. I've been watching the news reports though and tracking the news reports. So, the same week that sort of the flu vaccination recommendation was appeared to be downgraded from the federal level, there were multiple deaths reported in Massachusetts. And I believe North Dakota has reported their first flu deaths in more than a decade.
Hmm, Interesting. All right, for children under 5 years of old with influenza, are antivirals recommended if symptom onset is greater than 48 hours?
Yeah, it's a good question. So, AAP has said that if you are at higher risk for flu complications, then you can start antivirals um, irregardless of how long you've been sick. And kids under 5, but especially kids under 2, are at higher risk for complications. And so I think this is where the art of medicine comes in. AAP would say if you've got a 16-month-old who has flu, and they've been sick for longer than 48 hours, then yes, you can offer them oseltamivir, knowing that it's most effective. Um, I, I also want to point out that if you're getting sicker, if you're an outpatient who's getting sicker, and it's been more than 48 hours, start oseltamivir. Dr. McDonald, you can probably attest to this. We have kids who are hospitalized with complications of flu who were not treated with antivirals.
And then speaking to the art of medicine, with that situation if someone's getting worse after 48 hours, when do you consider antibiotics in a bacterial superinfection?
Yeah, I think this is where close follow-up is necessary. There is a classic pattern with flu where you're real sick at the beginning, you have high fever, and then you seem to turn the corner over a couple of days, and then the fever spikes back up. Oh, for me, that's a classic sign of a secondary bacterial infection. Um, we all know the literature talks about secondary infections with both Staph aureus and pneumococcus. We've seen a couple of cases of pneumococcal necrotizing pneumonia this year already.
Hmm. All right. And another question, what is the benefit of getting the combo meningitis vaccine? There is only one time that you give them both at age 16, or is the recommendation going down to 11 for meningitis B as well?
Yeah, great question. You're right. There's one time, really. It's that visit. So, if you could stock that vaccine and give it then and save a shot. Um, uh, before before the changes to ACIP last year that I'm sure everyone is familiar with, there was a lot of discussion about the meningococcal immunization schedule and did there need to be changes to the meningococcal immunization schedule? Those were paused on the federal level, and AAP has no new recommendations about that. So you're right. If you use the pentavalent in your practice, you'll have to stock multiple vaccines.
Okay. All right, Dr. Bryant, that's all the questions. Thank you so much.